Good morning. At least we get started on time. My co-moderator is not here yet, so I feel just free to get this started so we stay on time. I have the pleasure here to discuss, and you will hear interesting papers here about knee and soft tissue treatment, from bone loss in unis to special balancing techniques in severe varus knees. So it should be a pretty interesting section. I will start up with something that you hopefully will hear more about soon in your country as well. We have started in the US for 4 years now doing personalized partial knee replacements and bicompartmental knee replacements with this technology. And we have implanted in May the first total knee replacement. And I will give you a short preview of what's going to come. First, my disclosures here. I'm on the scientific advisory board and have stock options and receive royalties for intellectual property, and I get research support from OPED, and I get better. We all know that there are shortcomings with conventional total knee replacements. Almost 20% of patients undergoing total knee replacement have pain after surgery, and this has been published in several papers. One of the problems we have with current knees is imperfect fit, and we don't know really the clinical relevance of underhang in regard of loosening. There's not really, in my opinion, good science behind it, but overhang definitely has been shown to be a significant factor for pain after total knee replacement. In one study by Mahoney, he looked at 437 knees. He looked what happens if the femoral component had an overhang in more than 3 millimeters, and he saw this in 40% of men and 68% of women. Most frequently, this occurred in zone 2 and 3. You see this the anterior, the widest part of the femur, and the trochlear flange part. And the presence of overhang was associated with a 90% increase in the odds of a patient reporting clinically important knee pain 2 years after knee replacement surgery. And overall, about 27% of the outcomes of clinically important pain in this study are attributable to overhang. So it's a significant factor. Another shortcoming of conventional total knee replacement is internal rotation of femoral and tibial component, and we know that this has a clinical importance in our practices. Here in one study by Bedard, who looked at 52 stiff total knee replacements, he did 34 CAT scans in these patients, and he found tibial internal rotation or both. And he revised those knees, corrected the internal rotation, and he found that the Knee Society score for function pain improved clinically. In another study by Nicol of 740 consecutive total knee replacements, 8.2% had pain a year after surgery, and 56% of those had internal rotation of tibia, femur, or both. Other shortcomings is they really don't match conventional total knee replacement in regard to reproducing the distal femoral offsets. And we do know that, or we see this now doing individual total knee replacement, that this disbalance in extension by not matching the distal femoral offset is responsible for our ligament balancing. So what we do now is we know that the distal offset has quite a variance in knee replacements. And what we do is we put a symmetric femoral component always in one certain position. But we have a symmetric component that doesn't really match in all the patients. So the outliers are those where we end up in extension having a disbalance. But that's not the only problem we have with conventional total knee replacements in regard of the geometry of the femoral component. Also, the condyles are different because the medial condyle is longer and curved, and the lateral condyle is straight and short. And we also know, and this is actually old work here by Mensch in 75, that the medial and the lateral J-curve are different. We know that the J-curve consists of 3 parts, the posterior radius, the anterior radius, and the meniscal indentation. For implant design, the meniscal indentation is not very important, but the two radii are important. And you see here on his exams, and those are x-rays as well as cadavers, that the J-curves are different and have a different relationship. So the posterior radius is the same, more or less, between medial and lateral condyle. But the anterior radius is not. The anterior radius, you see the large circle, has twice the radius as compared to the medial radius. And also the ratio between posterior and anterior ratio changes between the medial and lateral side. So why is this important? Well, if you don't reproduce the geometry of the knee, you change the insertion of the origin of the ligaments, and you get disbalance. So we are forced to actually cut the ligaments because they don't fit with regular implants. So what you will see is that this technology, introducing individual total knee replacement, may address this. As a surgeon doing these implants, I see this already, but we don't have clinical outcome studies, but you will see that this will change things. One thing I want to point out at this point is that you will see x-rays that look different. This is a knee that is 2 weeks in, and you probably think, oh my God, this knee has medial wear because the polyethylene is thinner. No. These individual knees match the normal distal femoral offset. And the polyethylene, since the tibia is cut in 90 degrees, is whatever the offset represents on the femoral side to reproduce the mechanical alignment in neutral. So you will see knees that have different medial and lateral heights of the polyethylene, which is just matching the patient's anatomy. I go quickly about over certain things. We kind of virtually use a CAT scan, do a couple of slices through the hip and through the ankle, and then virtually pre-align the components along the mechanical axis of femur and tibia separately. The second thing is we take care of the residual cartilage since everything is CAT scan based. And there's a special tool in the set that actually reams the residual cartilage away so that and this is done on the femoral side and on the tibial side, to have the instruments, which are single-use and pre-navigated, log on and connect to the subhumeral bone to have the most accurate reading of the instruments. You see, we rely on basic principles of knee replacement. Fixation. The components are cemented. They have comparable pegs, comparable areas of contact in regard to where the cement interferes with the implant and bone. But you see here already there are patient-specific features such as the individual offset. Also, femoral rotation is a very important component. We don't rely on your classic anatomic landmarks anymore, which are 2D, like the white sides line, the posterior condylar line, and the transopercondylar axis. We rely on the reconstruction of the individual J-curves. So you cannot really inter-rotate that femur anymore because the geometry, the 3D geometry, gives you the position of the femoral component. On the tibial side, we actually try to be as advanced as we can to avoid internal and external rotation. And we all know that probably the most accurate way to position the component on the tibial side is a combination of the medial lateral tibial axis and the so-called the anterior third of the patellar tendon insertion. So the way how this is designed, this component, is we use as a maximum external rotation that is allowable, Cobb's method, where the engineers define the center of rotation of the medial and lateral tibial plateau, and the normal axis to it is the max external rotation that this system allows. The tray, however, is slightly undersized. So the surgeon can now internally rotate a little bit towards the tibial tubercle, to the medial third, and that angle is not very much. It's maybe a 5 or 10 degrees. But the individual size tibial component, which is slightly undersized, allows that. We rely on gap balancing. Why is that? Well, we know it's the standard, a classic standard, and I'm glad that Chit Ranawat is here, who taught us this for years and years and decades, and still, I don't think more than 10% are done with this technique. This system will use this technique, and we use inflection, a spacer that avoids over-external rotation and prevents internal rotation by bringing a spacer block in that is slightly larger on the lateral side, which internally rotates the femur, but externally rotates the femoral component, avoiding over-external rotation if the posterior lateral structures are too loose, and preventing internal rotation, as I mentioned, because of the reconstruction of the J-curves. You see here how the femur looks. It matches the normal anatomy, but with the external rotation of the tibial component, we decrease the lateral flexion gap to get an equal balanced flexion extension gap. Then the surgical technique, single-use instruments that are pre-navigated. Here on the femoral side, it's relatively simple. It's like what you know from other patient-specific guides. The placement of the pins is the importance. Then you cut it, and the same is on the tibia side. And I mentioned that we remove the cartilage before we measure it. The preparation of the components for the tibia is in the standard fashion. There is no surprise. We balance the extension gap with a spacer block, which is then also done in flexion with a very simple system determining the position and the chamfer cuts of the femur, which is really as compared to other total knee replacements. The accuracy is, this is FDA data I show you. We don't have larger studies yet, but the accuracy is less than 1 millimeter deviation from the plan in those cases submitted to the FDA. Also, since the component is designed in a way individually where the chamfer cuts are, the component can be thinner and preserve more bone. We estimate that about 50% less bone resection on the femoral side as compared to standard conventional total knee replacements. And since the coronal plane of medial and lateral condyle is actually individually engineered, we can increase the contact area, but not changing the curvature on the tibia side. We don't increase the constraint of the polyethylene. So we have a fourfold increase of contact area compared to a fixed bearing, and a twofold increase compared to a rotating platform knee, decreasing the polyethylene stress and hopefully polyethylene wear. Radiographic results, as I showed you, be aware that this is not medial wear. This is just an individual total knee replacement that you will see more about. The reconstruction of the mechanical axis, we rely on traditional mechanical alignment. And what you see on the lateral films is, besides the anatomic fit of these components, that you have two J-curves that are different. Medial and lateral condyle are different. Surprisingly, the patella tracks much better because the lateral condyle is smaller, right? It's flatter. So the patella has much more space to sit over the lateral side. And I show you here a series of 9 consecutive total knees, and I don't see a tilt subluxation or a translation of the patella anymore, because the patella tracking is just individually much better achieved with these asymmetric total knee components. So patient-specific total knee replacement addresses, in our opinion, several issues that conventional total knee replacement cannot do, such as restoring the distal femoral offset, restoring the J-curves, hereby restoring the origin and insertion of all ligaments. We prevent malrotation of components by design issues and the way how components are designed and integrated into the surgical technique. And early experience of now over 70 total knees in the US and in Europe here shows that we don't really do ligament releases anymore. Currently, we limit ourselves to mild deformities between 15 degrees of valgus and 10 degrees of varus, but we have done more severe cases and we see the same thing. Thank you very much. Maybe I just take one or two quick questions before we go to the second talk. Are there any questions? If not, I'm pleased to announce Franz Köck from Regensburg, and he's going to talk about the individual technology and early results in partial individual patient-specific